I request last speaker, Dr. Rohit Gupta. He will be speaking on management options for pediatric eye allergy pathologies.
So, good morning, everyone. I feel very honored to share stage with my teacher, Professor Jagat Ram sir, Professor Ashok Sharma, and I thank Dr. Rishi for giving me the opportunity to talk in front of the conferences. So, my topic today is pediatric allergic conjunctivitis. As we know, the season of summer and spring is started, so we have seen lots of patients of allergic conjunctivitis in children as well as in adults also. I'll be restricting my talk to the pediatric age group. Slide down. So, as you know, we have this India is a land of diversity, so we have a broad range of allergens present in the environment. So, major allergens in India we have seen is pollen grains, fungal spores, insects, dust mites, irritants, pollution, as well as pet dander. So as you can see, there are wide ranges of allergens which can cause allergy in pediatric age group. So it's documented like temperature-related changes in the airborne allergic pollugens can increase the pollen in the environment, and this can cause allergic conjunctivitis in children. So these temperature extremes, as we can see in summer, and so it leads to extended seasonal duration and increased pollen load in the environment. So it can impact duration of symptomatic periods and symptoms severity of the allergy. So elevated temperatures and high CO2 levels have increased the pollen load in the air. So this can increase directly leads to the symptomatics of the allergy. So the allergens, these are foreign body or antigens, which are we have mentioned before. Allergy is the hyperimmune response to the corresponding antigen. It's more common in the hot and humid tropical climates. So the 40% is the global prevalence of the allergic conjunctivitis. Worldwide prevalence, as you can see in this picture, is in India is around 25 to 5%. It's more common in the African region, Japan, as well as US also. So, what is allergic conjunctivitis? It is predominantly an IgE-mediated allergy that is induced by the allergens on the ocular surface. There are various types. One is seasonal allergic conjunctivitis, other is perennial allergic conjunctivitis. As you can see from this name, seasonal is seasonal from March to April, or in the changing environment of September to November. Perennial is throughout the year. VKC is vernal conjunctivitis. It is chronic severe form. Others are atopic as well as giant papillary conjunctivitis. I will limit my topic to the seasonal, perennial, and vernal conjunctivitis. Symptoms of allergic conjunctivitis are redness, itching, watery discharge, pain, as well as swollen eyelids. You can see from this picture. The itching is the most common and disruptive symptoms of the allergic conjunctivitis. So what is the pathophysiology of that? First is the first exposure of allergen to the eye, which causes sensitization. As you can see from this, the exposure of allergen causes, it is processed by the dendrites as well as T cells. These are the immune cells as well as first process of the antigens. These dendritic cells and T cells releases specific IgE antibodies. These IgE antibodies, they bind to the inflammatory mast cells. So this is the first exposure of the antigen to the eye. This is the process which occurs. So on subsequent exposure, there are two phases, early phases as well as the late phases. The early phase is like sensitized mast cells, they come in contact with the allergen on subsequent exposure, which causes degranulation of the mast cells. These releases various inflammatory mediators like histamines, leukotrienes, as well as this inflammatory mediator interleukins also. These histamines, they act on the smooth muscle cells, blood vessel cells, mucous glands, blood platelets, nerve endings, as well as on the eosinophil cells. So the itching is the most early phase of symptoms, also with redness and watering. The late phase occurs around 2 to 4 hours after exposure of the antigen to the eye. So on this exposure of Ig with mast cells releasing histamines, they further releases leukotrienes and prostaglandins. These causes have effects on the blood vessels as well as eosinophils, basophils, and the T cells. These all releases chemokines and cytokines in the eye's tear film. These have the symptoms on the eye, like you can see the redness, tearing, watering, itching, as well as all surfaces. So the histamines, the most common first release of the histamines, they bind on the histamine receptors, on the H1, H2 as well as the H4. The H1 is present on the conjunctival neurons, which causes itching. The H2 is present on the endothelium, they causes redness and swelling. The H4 are present on the mast cells and eosinophils, and they causes itching and inflammation. The seasonal perennial, the itching is the hallmark symptoms. Along with we have redness, tearing, photophobia, and discharge. The swelling of the eyelids usually present, and the eyes have a glassy look due to conjunctival swellings, as you can see on this picture. The SAC is mild to moderate injection on chemosis. The chemosis is present on the prominent on the nasal conjunctiva because they are loosely adherent on that area. The swelling of the lids causes narrowing of the interpalpal fissure. Papillae are present mostly on the bulbar conjunctiva. They recur seasonally with changes in the pollen and the allergen presents. They have mild or local inflammations. They often resolves and remits. The other form is the VKC is vulnar conjunctivitis. They need to be differentiated from the SCC and PAC because of the potential for the vision losses. The symptoms begin in the childhood and they peak around 11 to 30 years of age. They mostly occur in the springs and the summer months. As you can see, the vernal is the Latin word and causes known as spring. The ryegrass is the most common cystidating agent. The other agents are the pollens, the mites, animal dander. There are other non-specific like sun, dust, and the wind exposure. They have a bilateral intense itching, which is characteristics of VKC. The other symptoms like is more or less similar to SAC is tearing, photophobia, spasm, blurred vision, and discharge. Pain occurs if there is involvement of the cornea. They typically have seasonal exacerbations, with at least 60% of them have recurrences year around. And approximately 60% of the patients with seasonal exacerbations, they progress to experiencing perennial VKC symptoms. 49% of the VKC patients, they have family history of atopic disease like asthma, rhinitis, or eczema. The types we have like palpable, limbal, and mixed, and the HT dots. These are the colboidal appearance of the conjunctiva or the palpable region. The other is this limbal form. We can see the gelatinous appearance at the limbus, and the mixed is combination of both. The corneal calculations can be due to punctate erosions, which coalesce to form the microerosions. The other complications we have like shield ulcer, which we can see these are the superior shield ulcers mostly in the superior cornea regions. The main cause is the major basic protein in this conjunctiva. The management is non-pharmacological like avoidance of allergens, cold compresses, irritants. Other is pharmacological. Pharmacological we have like topical eye drops in the form of antihistaminics, the mast cell stabilizers, as well as NSAIDs and as topical steroids or oral steroids, depending upon severity of the conjunctiva. Oral we have oral antihistaminics. We can see the class of the this antihistaminics and anti-allergic medications. So they are effective responses, well tolerated, and good compliance. So the impact can be decreased quality of life, school absenteeism, loss of work days, failure to sleep, increased cost of treatment, as well as visual threatening complications like shield ulcer, corneal opacity, scarring, as well as keratoconus. So thank you for this.